Okay. Good evening, everyone. Welcome here. It's my pleasure to see you, so many friends, colleagues, and also new friends here at Think Corner. This is the third ever CLUE Working Group lecture, which we can now say has become a tradition. So today we will have a Rita Redberg, and I will introduce Rita later. CLUE Working Group is a research group funded by Academy of Finland and Sigrid Juselius Foundation and Helsinki and Uusimaa Hospital District, and we are extremely grateful for the support. We aim to deliver improvements in urology and other areas of medicine by using state-of-the-art clinical epidemiological methods. We also are interested in knowledge translation of the issues which we believe are important, and one of these endeavors are the CLUE Working Group lectures. Today we are having the third CLUE Working Group lecture. The first one we had just the other side of the street a couple of years ago by Alan Francis, who was the chair of the DSM-4, the Bible of Psychiatry, and he gave us a fascinating lecture on a definition of disease and how slippery it is. Then last time Richard Smith was giving another fascinating lecture about failures of journals and how we could maybe do dissemination of science better and what are the troubles. Today we will have a third CLUE Working Group lecture, and then actually these are roughly annual, but this year we are going to have a second one also. The fourth lecture is going to be by Mo Bandari, who is a world leader in trial methodology, especially in orthopedic surgery, but also outside, and he's going to give a talk on Think Bigger and the new culture of surgical trials and trials in general. I use this opportunity to also make knowledge translation of the upcoming Too Much Medicine Symposium, which is going to be here. I see a couple of the organization committee and also in the audience, and so we have a good team who has been working to get world leaders and chaired by Teppo Järvinen and another Secretary General Jarno Hutanen and an amazing team. We have been able to get funding, and the Paolo Foundation is funding actually this world-class event where we will have a bunch of world-leading experts of evidence-based medicine, investigative journalism, etc. Some may know the people like Gordon Guide or Paul Glassy or Iona Heath, for instance. So please save the date 15 to 17 August and go to the website toomuchmedicine.com. Actually, it's going to be in Helsinki, so you shouldn't have to go too far. And the registration is now open. There's early bird fee of 450, and it's cheaper for students. It's for free for the students who just hour ago were competing in Helsinki Think Company multidisciplinary channel. So we are having a very interesting day today, and we saw some amazing results, and one of the groups who didn't even win is going to get their work on the JAMA Internal Medicine website, and the winner has already contacted the Finnish Pharmacy Association and Kela, so we are really happy that actually the challenge made a difference. So, please, this is Sleepy Asklepi. Sleepy Asklepi is one of the mascots, or the only mascot of the Too Much Medicine, and also go to the social media and follow us on. If you're middle-aged, use Facebook. If you're young, use Instagram. If you're both, use both. And then on Twitter, everyone is welcome to follow us also. But today is, by the way, do you hear me well, or, yeah, good, thank you. So today is my great pleasure to have a Rita Redberg here. Rita is, if you didn't know yet, she's a cardiologist, professor at the UCSF, San Francisco, California, United States, still not yet independent. And she's also editor-in-chief of JAMA Internal Medicine. When I ask her, how would you like me to introduce yourself? she didn't really know what to say. But then after a minute or two, she had two really nice ways to introduce. The other one was a little bit less boring. She came here just to see snow. That's why she went to Lapland before the trip. But then she said, no, that's not really the case. Actually, why she came here, what's other thing what she wanted me to tell was that she's on the top 10 list of the threats to interventional cardiology by Society of Interventional Cardiologists. So this was another way she wanted me to introduce her. So after Alan Francis and Richard Smith, it's my pleasure to have you, Rita, here and give your talk today. And anyone, please, big hand to Rita, and anytime you can interrupt us.
Thank you. Thanks so much. I really am delighted to be here, and we did enjoy some cross-country skiing yesterday in Lapland, which I cannot do back at home. But I'm really delighted to talk about one of my favorite topics, how less healthcare can sometimes be better for you, and the too much medicine challenge that I just had the privilege with Kari and Henry to judge was really inspiring, and I love to see all of the ideas and energy from the younger generation. Because they all had great ideas and things that I hope we'll continue to see, and a lot of things that I'm going to talk about now. So I just thought I would start with a little bit on my background, where I came from. I grew up in Brooklyn, New York. As I say, Brooklyn before it was hip, because now it's, when you move to New York and you're 20-something is where people want to live, but not when I grew up there. I was happy to leave. But I grew up in fairly modest circumstances, and I think neither of my parents had gone on to college or actually finished high school. And so I learned a lot about not wasting things, and I think that did have a lot of influence on sort of my later professional life and what I'll be talking about today. I did put myself, along with generous scholarships, through college and medical school. This was 30, 40 years ago when things were much less expensive in the United States. Now I don't think it's possible. But I did certainly learn the value of working and not wasting things. And I did very lucky to work at the University of Pennsylvania, where I was in medical school with John Eisenberg, who went on to become the head of the Agency for Healthcare Research and Quality in the US. And at that time, he was doing a study to try to get the house staff, the trainees, to stop ordering so many lab tests. And he did it by sending little notes to them, because this was before email. And the notes really had no effect at all on the house staff ordering behavior. But it did have a big effect on me. I was a second-year medical student, and it made me start questioning and saying, maybe not everything that my older doctors are doing and modeling is something that necessarily is based in evidence, and that it's okay to question this behavior. So I actually took a year sabbatical during medical school and got a fellowship from the University of Pennsylvania and studied health policy at the London School of Economics. And also at that time I had a National Health Service card, so it was very eye-opening for me to see how a national health system worked, and to see what it was like to be a patient in a country where people frequently would say to me, well, maybe we have to wait a little bit for health care, but at least nobody dies waiting outside the emergency room for care. And so it really made me start thinking about the bigger picture and health policy, and that was how I came to start looking a lot at technology. And because I think a lot of what we spend a lot of money on in healthcare is in technology. And so when I went into cardiology, it was partly because I really enjoy cardiology, which is a great field, but partly because we also use a lot of technology in cardiology, and I was very interested to see more carefully on which was actually leading to better health outcomes and which was just adding to our incredible high healthcare costs without actually helping patients. So this is just a slide just to show that although the costs are much lower in Finland and everywhere really outside of the US, healthcare costs are indeed going up. This is from the official statistics of Finland. So even in Finland and everywhere in the world, the rising cost of healthcare, I think, is a concern, especially because it tends to cut into other social service budgets like education and social services. And so that sort of brings me to the less is more concept. And I think currently what we are teaching in medical school has really changed since when I was in medical school. And now we have a general attitude that if some medical care is good, then more care is better. And that we tend to embrace new technology and feel that something new, and particularly if it has a lot of features, a lot of bells and whistles, that is better than older things, or better certainly than no technology. We also, I think, tend to believe that a medical test can't hurt, and that prevention is now often talked about as having a test, like a cancer screening or a cardiac screening, where I actually think prevention really should be talked about in terms of lifestyle choices, and that prevention is still kind of things that are not as sexy and glamorous, but things probably your mother told you, eating a healthy diet with a lot of fruits and vegetables, getting regular physical activity. I have been impressed with all the bicycles that I see in Helsinki and even in northern Finland, even despite the snow that was still everywhere in Lapland, people were out on their bikes. And not smoking, of course. And I think medical care needs to be the right test for the right patient at the right time. And so what we try to do in the less is more section is really focus on the fact that if a test or a treatment has no benefit, then no risk is acceptable, and that actually a test can hurt, and it's certainly not going to help. And so that's what I wanted to go on and talk about for the next hour or so and just give some examples. This is just some comparative data. Certainly, when I was studying back in the London School of Economics, that was 1980, the US was where Finland is now. I think we were at about 9% of GDP. And people were saying to me that, or saying in the health policy world, well, when it crosses into double digits for the US, that's when people are really going to start paying attention to why we're spending so much more on healthcare than the rest of the world. Because at that time, most of the OECD countries, I think, were about 6%. But as you can see, Finland's doing pretty well and doing better than the OECD average. And certainly, if you want to feel good, you can always look at the US because we are way above in terms of percents of GDP, and certainly experiencing, I think, a lot of the crowding out for education and other social services because of these high health costs. And 75%, this is from Finland, of health spending was public sources in 2012, and I understand there's discussion of privatization of healthcare in Finland, so please feel free to bring that up in questions and answers or during the talk. It's a small enough group that if someone has questions, just let me know, and we can go right to them. So we launched back in 2010 this series, How Less is More in the JAMA Internal Medicine. And a lot of the examples I'll take, they're not all from my journal, but I admit, have a bias towards JAMA Internal Medicine. And so we introduced the series with the idea that we wanted to publish research, and we really wanted to stimulate an international discussion to get people thinking about, well, there could be harms to healthcare as well as benefits. And so we launched the series, and we're very happy that other journals, the BMJ now has a Too Much Medicine series and has published a lot of really excellent articles. This one was setting a research agenda for medical overuse and really looking at some of the, trying to be very rigorous about looking at the questions, because for a long time we have focused on underuse, which is certainly important. But to me, we have to, if we're not going to spend infinite amounts of money on healthcare, which I don't think we can or should, then we have to sort of look at overuse and try to shift so that we can get things more correctly and reduce underuse as well as reducing overuse. This was some early work actually from Kari, looking at sort of the definition of what is a disease. And it was a very interesting survey, did a Finnish doctors, health professionals, as well as members of parliament, but really showed how the definition of disease is changing and is very different depending on who you ask, and also very different depending on what you think the source of funding is to treat the disease. But I think one of the things we've seen over the last 10 or 20 years is that we've kind of medicalized now baldness is, we give it a name, some things that used to be reflux or stomach upset now gets the name of gastroesophageal reflux disease, and then we get all kinds of treatments with it. So this was just one cartoon. Offhand, I'd say you're suffering from an arrow through your head, but just to play it safe, I'm ordering a bunch of tests. And I think this is, unfortunately, not because of an arrow, but that we do see a lot of tendency to feel like I'll order a bunch of tests because more information would always be better. And so I wanted to talk a little bit about some of the specific studies. This one is called Low-Value Medical Services in the Safety Net Population. So safety net in the US is population of people that get publicly sponsored health care. And the idea of this study was to look at whether or not there was, because you're going to spend less on, generally people are spending less on publicly funded healthcare than on private healthcare. There's always a two-tier system, I think, with public and private funding, was to look at, well, was the savings because there was less low-value care in the publicly funded system? And so what these researchers did was look at Medicaid, the publicly funded system, as well as privately insured patients over a fairly long time period. And they took 9 measures for low-value care, I'll show you what they are, and 12 measures for high-value care. And so these were some of the examples. For low-value care, they had antibiotics for upper respiratory infections, because upper respiratory infections are generally viral, and not only do they not benefit from antibiotics, but it can lead to superinfections in the person taking them, as well as superinfections in general. That's why we have problems with resistant bugs currently. Things like advanced imaging for sinusitis, which again is not recommended. It's almost to the choosing wisely list of things not to do. And other things, inappropriate imaging for low back pain. And then the high-value measures were things like telling people who smoke to stop smoking, telling people who are obese to lose weight and giving counseling, and medical treatment for coronary artery disease. So things that have been shown to work and be of high value. And so they looked at these measures in the population and found that there actually wasn't any difference between the low-value care and there wasn't any difference between the publicly funded and the privately funded in terms of low-value or high-value care. And that there was, they said, no difference in 7 of those 9 low-value measures, and that actually 2 of the low-value measures, and they both were inappropriate use of narcotics, narcotics for low back pain and narcotics for headaches, were more common in the Medicaid patients. And we can talk, if you like, why that would be, but it certainly didn't prove the theory that publicly funded care was costing less because there was less low-value care. And similarly, there wasn't a better use of high-value care. So, so what I said is that I would hope by reducing inappropriate spending, then we can spend more on things that we need. And clearly, that could happen, but it's going to take some thought and some work, because this study showed that, first of all, only a third of visits delivered high-value care, so did things like the tobacco cessation counseling. And they said the uninsured were actually more likely to receive high-value care than privately insured, but the Medicaid patients receive less high-value care. So it was an interesting study, we thought. This study looked at how to try to influence patients' behavior, because we talk a lot about shared decision-making and how to have patients accept that there are certain things they don't need, because I think for a lot of reasons, mainly because doctors and public service announcements for many years have been telling patients that testing is good, and particularly with the cancer screenings, that early detection is better. And so now that the data suggests that that may not always be true, it's a very confusing message, I think, and hasn't been that clear to communicate. So what they did in this study from University of North Carolina is they did a randomized trial. So they actually took a large population and they had 4 different formats in which to explain to them why they didn't particularly need, they were certain cancer screening tests, and the population they were talking to didn't fall in the target group. Maybe they were too young or too old for the tests. Like most of the cancer screening is only recommended when you after age 50 and ending at age 75. And so basically what they did is gave them 4 different formats, some with pictures, some with numbers, some that just had text, but none of these formats had a very impactful effect on whether or not these patients wanted screening. And what they basically think, perhaps they were already coming to the doctor convinced they needed screening, and this 1-pager was not enough to change their behavior. And they concluded that the interventions had little effect, and that decisions were driven more by cognitive biases and not by this at least 1-page accounting of harms and benefits. And not to say that I don't think talking to your patients about harms and benefits is not useful. I think it is, but I think it has to be more than this 1-page, or at least particularly a 1-page when you get a barrage of other information that's all is oriented towards the idea of doing additional testing and additional screening. And I think that's a lot of the reaction we hear when, for example, the U.S. Preventive Service Task Force changes recommendations and says things like, well, mammography is not useful for women who are between the ages of 40 and 50, and there's a lot of pushback. I think it gets confusing for patients to hear different messages. I wanted to give a few examples of the kinds of cancer screening that have become more popular but have not resulted in any benefit. It was a thyroid cancer example from the BMJ. And generally, one of the ways of looking at overdiagnosis is exactly like this. When you see the rate of cancer going up, but the mortality rate, which is here in the red line, staying exactly flat. So that tells you that we're diagnosing a lot more thyroid cancer, and this shows you all of the different interventions. We have more and more ways to diagnose thyroid cancer, and so with each one, we're diagnosing more, but you can see that the mortality rate from thyroid cancer has been absolutely flat. And so for all of the additional cancers we're diagnosing, there has been no drop in the mortality, which suggests that we are overdiagnosing. When they say most thyroid cancers are very slow-growing and benign, and that perhaps certainly suggests that we're overdiagnosing thyroid cancer. And that was, and they showed this over a 30-year time period. Again, for breast cancer, as I said, this is a very sensitive issue. We've given women the message for many years about the benefits of mammography, and then there is recent data that leads some to question mammography entirely and some to question the more frequent use of mammography. The current U.S. Preventive Services Task Force guideline recommend mammography every 2 years for women between the ages of 50 to 75. But I know, for example, at UCSF, when a woman gets a mammogram, the radiologist sends the report home, and the radiology report says, come back in a year for your next mammogram. And then I've had patients ask me, my GP told me come back in 2 years, but the radiologist report says come back in a year. And we have that kind of confusing messages for patients about cancer screening and that in general. So this study from the New England Journal looked at the effect of increased mammography on cancer tumor size. And it was a similar idea to say they looked at the size of tumors that were being diagnosed over a time period where there was increasing breast cancer screening. And so you can see here's when 1985, when mammography became very widespread. And you can see that there was an increase in invasive breast cancers diagnosed, but no difference, again, in the diagnosis of metastatic breast cancer, and a higher proportion of small detected breast cancers. So they went from 36 to 68. They just about doubled over that time period. The proportion of large breast tumors decreased, but they said that the change was due to overdiagnosis, and that there has been a small change in breast cancer mortality over that time period, which the researchers attribute to improved therapy because we've gotten much better at treating breast cancers, but that they said that change hasn't been related to the increased use of mammography. And now, of course, there's increased use of other kinds of breast imaging. There's breast MRI and breast digital tomography. And I think with all of these more sensitive techniques, you get more and more diagnoses of lumps and tumors, and that creates a lot of anxiety and a lot of additional testing like biopsies and mastectomies. But again, hasn't been shown to have a reduction in breast cancer mortality for all of that additional breast cancer imaging. And the last cancer screening example is one that I'm particularly interested in, lung cancer screening. And this one looks at the use of CT and chest radiography before and after the screening guidelines. So, you know, again, the U.S. Preventive Services Task Force in about 2014 came out with screening guidelines giving lung cancer screening a grade B, meaning that it was recommended, and in particular in the U.S. where most people are privately insured, it meant that your insurance had to cover it without any out-of-pocket payments, because most things patients, even with insurance, have to pay out-of-pocket for. So when that happened, the percentage of people who were screened for lung cancer increased, because now there was a big public campaign for it, not just a public campaign, but what, as often happens, you know, the CT scanning equipment is quite expensive. It's usually about $1.5 million, maybe 1.2 million euros. And so once you buy the equipment, the hospitals that have purchased it tend to advertise that they have lung cancer screening available. And in fact, the advertisements don't necessarily say who should be getting it. They don't say only if you have a long smoking history and the other particular criteria. And so what they found in this study was that it was true that the rates of CT scans had gone up, but that actually most of the CT scanning for lung cancer was occurring in never smokers and low-risk smokers. So if you know the criteria for lung cancer screening, it's never recommended in never smokers or in low-risk smokers. It's only recommended in high-risk smokers, because like most things, you know, the difficulty for any screening program is that it's very hard to have a test that's accurate enough to accurately diagnose disease in a population where there's a low prevalence of disease. That's Bayes' theorem. And when you have an asymptomatic population, which is what we have in screening, you have a low prevalence of disease. And you have particularly low prevalence in never smokers and low-risk smokers. They're going to have very low rates of lung cancer. And so this test is always going to perform better in a high-risk group because they're much more likely to have the disease, and that's who the recommendation was for. The problem is, as I said, there is not very good application of the criteria for many reasons, and most of the increase in CT scans occurred in people that would never benefit, and there are harms, which I'll talk about. So this was another study that, this was a study we published in JAMA Internal Medicine about a year ago that looked at the implementation of a lung cancer screening program at the Veterans Administration Hospital. So the Veterans Administration in the US is a federally funded hospital system. Doctors are employed by the Veterans Administration, by the government, and so they're basically on salary. The incentives, they're not on a fee-for-service system like most private hospitals are. So they had a very rigorous program where they talked to all the veterans who met the criteria, so only high-risk smokers, and offered them free lung cancer screening. And we published their findings, which I'll talk about in a moment. You can see here that the lung cancer screening programs found incidental findings, so things totally irrelevant, but that you happen to find when you do a lung CT, but they exceeded the number of lung cancer nodules found by 40 to 1. So you had 40 times the chance of having an incidental finding from a lung cancer screen, even in this high-risk group, than you did from finding an actual lung cancer. So this is, as I already told you, this was the evaluation at the Veterans Administration, which is mostly men for lung cancer screening who met the task force criteria. They found that it was very complex to actually explain what would be the possible benefits, what would be the possible harms of this lung cancer screening program. And actually, only about half of all the patients that they offered the lung cancer screening to agreed to have it after understanding what the harms and the benefits would be, even though the test was free. But more importantly, perhaps, they found that most of the patients did have findings that required follow-up, so it wasn't like you had the test and you were done, and that few people actually had early-stage cancer, which is the goal of these screenings, is to find early-stage cancer that you can treat early and make a difference. And so these are the actual results. So a lot of people do have nodules just because a lot of people have lung nodules, particularly in this population of high-risk smokers, and that more than half of them did require tracking. So now you're told, well, you have a nodule, we don't know what it is, but come back in a year and we'll do another CT scan. It might be cancer, it might not be. So I can't imagine that you feel better after having heard that from your doctor. That 2% required further evaluation, but the findings were in cancer, and 1.5, so not very many, actually had lung cancer, but that the rate of false positive test results for lung cancer was 97.5%. So there was a very high rate of false positive findings, and that was actually been consistent with the other studies that have been done of lung cancer screening. And I'll say, the reason I said that I'm particularly interested in this issue is because I chaired the Medicare Evidence Development and Coverage Advisory Committee for 4 years in the US. And this was the committee of experts that was supposed to advise Medicare on various technologies. And so one of the technologies we were asked to advise on was lung cancer screening. And I will say, as the chairperson for that committee, I did not vote, but the committee, after hearing all of the evidence for the harms and benefits, voted overwhelmingly that they had low confidence that the screening benefits outweighed the harms. In other words, because there were so many false positives, there were so many additional procedures that had to be done, there were so many incidental findings, and because there were very few actual lung cancers being identified, and that lung cancer screening was actually very hard to do, so there was not good reproducibility between radiologists for actual readings of lung cancer because it was so difficult to do. So for all of those reasons, and because we saw evidence, like people came and testified and showed us ads from lung cancer screening programs that said, you don't even have to be a smoker, come in and get the CT test. So clearly they were going to be overused, and sadly they were going to be overused. So the committee voted harms would, they had low confidence harms would be minimized. However, as happens, the committee, even though the committee clearly had a negative vote and was not convinced that lung cancer screening was ready for prime time, there was a huge lobbying effort by the radiologists, by the thoracic surgeons, and by some pulmonary doctors to Congress, who consequently lobbied the Medicare agency, and also because the U.S. task force had already said that they thought the harms, the benefits exceeded the harms for people less than 65, because for Medicare we were only looking at the evidence in people older than 65. So for all of those political and other reasons, Medicare did decide to cover lung cancer screening despite the vote of the committee. Yeah.
Do you want to comment anything on the impact on mortality?
Sure. So for the National Lung Screening Trial, the one that was done in the U.S., so this was a trial that was done comparing CT scans to chest x-rays, and that trial was the basis for the task force recommendation. That showed a benefit on mortality, 5%, I think, I don't remember the numbers. I think it was about a 5% benefit on lung cancer, and there was a small benefit on all-cause mortality. However, there were 3 or 4 European randomized trials that showed no benefit on mortality. And for inexplicable reasons, because we asked the people that came why they didn't, because usually if there's 4 well-done randomized trials, you would look at them all in totality. And looking at them in totality, there was no benefit. If you only looked at the US done trial, that was the National Lung Screening Trial, then there was a benefit. And that was the only trial that was used. Not only that, but before they even started the National Lung Screening Trial, there had been studies done comparing doing screenings with chest x-rays to not screening for lung cancer. And the group that got chest x-rays had a higher mortality. They were more likely to die. So to me, it didn't make any sense to, after you knew that chest x-rays were more likely to lead to high mortality, why use that as the control group in the study of CT scans for lung cancer screening? Because obviously, to me, you're going to bias against that arm, because if you do chest x-rays, I think most of the harms are coming from the fact that you're finding so many things in the lungs that are not lung cancer. And so if you just leave people alone, they don't have that problem. But instead, the National Lung Screening Trial had a chest x-ray control and compared to CT scan. So the CT scans looked better because they were being compared to another technique that also had all those problems. And I asked the principal investigator of the National Lung Screening Trial, who came to the Medicare meeting, why did they use chest x-rays as control? Why not just not do imaging? And he said he didn't have a good answer. So yes, there was a benefit seen in that one US trial, but I have reasons for concern that that's not a real benefit. And the problem is, like the mammography, once you start doing something, it's very hard to ever pull back. I mean, to me, these cancer screenings are like a speeding train, and they just take off, and you've bought the equipment, you've invested in training, people are now convinced this is a good thing, and it's very hard to pull back. And so that was why, for all of those reasons, the committee advised Medicare, not to approve lung cancer screening at that time, but politically that was very difficult.
And it's really unusual to use only one trial, not the total evidence-based. The only good reason to only use one is that's clearly better quality trial than the others, and that's really not the case.
No, I thought, honestly, the European trials, 2 of the 3 European trials had no imaging at all, which I thought was a much more realistic control and should have been included. This is, again, from the VA study that I just showed you. They looked at, so for every 1,000 people that they screened, 10 would potentially benefit, so 1 in 100, because they would have early-stage lung cancer. 5 would be diagnosed with late stage, so too late to help at any rate. 20 would undergo unnecessary invasive procedures, and 550, so more than half of those 1,000, will experience unnecessary alarm and repeated CT scanning with the associated risks of radiation and increased cancer risk because of the number of false positive findings. Okay, so, and that was just, I think, another screening and editorial, which basically can be summarized here, which shows that you're most likely to benefit to have a lung cancer diagnosis if you're in the high-risk group. This is particularly, they used what's called the Bach risk score. There are lots of different risk scores. But that the screening effectiveness, this is if you're in the lower risk group, and these were still all ex-smokers, this is number needed to screen to prevent 1 lung cancer death. So you can see in the low risk group, the ones who are most likely to get CT scans, you need to screen 7,000 people to prevent 1 lung cancer death. And that's not even looking at all-cause mortality, that's lung cancer death. In the high-risk group, it was about 600 or 700 needed to screen to prevent 1 lung cancer death. So again, it just shows the importance of risk stratification for any kind of cancer screening program. And so they concluded that the initial screening was least effective in the low and intermediate risk population, and patients need to be risk stratified prior to screening decisions. Let's say we have, and I'll talk, an editorial fellow program at JAMA Internal Medicine, so we try to include some of the house staff who are particularly interested in journal writing, and they work with us throughout a year or two during their elective time. So Mike Inze is one of our editorial fellows, and he and I wrote this editorial note, but he wrote the title, Back to the Future, because they had used or Back to the Future, because this study was the one that used the Peters Bach risk score, and I'll just say Peter Bach, if you know him, is an oncologist at Cornell. I told me he has a framed picture of the article now. He feels very special to have his name in a journal title. So we were happy to hear that. Okay, so I just want to talk about cardiology, not mention my own specialty for a little bit. And so this in particular is, I think, a common problem in low-risk chest pain. And when I say low-risk chest pain, I mean chest pain, you're coming in, clearly you're not having a heart attack, you don't have ST elevation on your EKG, you don't have cardiac enzymes leaking, but you have some kind of maybe chest pain. And chest pain is now defined very broadly, so it could be shoulder pain, it could even be shortness of breath, but someone is thinking maybe this could be a heart-related issue. So this was, I thought, an interesting study where they tried to look at it. So if you came in and your EKG was normal and your enzymes were negative, the American Heart Association guidelines say that you should have a stress test, some kind of exercise test, within 48 hours. And so this study attempted to look at, were people better off? Because that's really a lot of testing. We see lots of people, and I'm sure you do as well, in Finland, who have this kind of low-risk chest pain. And so they did this very large analysis of almost 1 million patients who presented to various emergency rooms with this low-risk chest pain. And the outcomes were, did you have a heart attack at the end of the year, and did you get additional testing? And so they used, I'll say the characteristics. So you can see right away this is a low-risk population, because I'll tell you, anytime in cardiology when there's more women than men in the study, it's a very low-risk population. If you look at unfortunately, the studies that look at cardiac treatments, generally they have 20% women, 30% women, even though women do make up half of all patients with heart disease. For reasons that I can't explain, they're under-enrolled in clinical trials of cardiac treatments. But in trials of low-risk chest pain, there's mostly women. Partly it could be because of the red dress campaign that I see a lot of patients that come see me in my cardiology practice and say, well, they're a little tired or they have this funny jaw pain, but they read that women can have atypical symptoms and it could still be heart disease. And I think that kind of increased awareness, unfortunately, makes a lot of women who don't have heart disease concerned. But it's pretty unusual for people in their 40s to have heart disease, and certainly for women in their 40s. So at any rate, you can see right here, it's a low-risk population. And what they found was the people that did have the early testing, and they used within 30 days, were more likely to have more tests. So they were more likely to go on and have coronary angiography. And of course, once you have coronary angiography, even if your symptom may have had nothing to do with ischemia, if they find, I mean, there are people that have some blockages in their coronary arteries that don't have any symptoms, and we don't know how that affects their outcome. But once you find something in the cath, it's generally, you get a revascularization. So those were increased, but there was no significant change in acute myocardial infarction admissions, which was their sort of index for whether they were really affecting cardiac outcomes or not, which, unfortunately, you'd need an even longer and bigger study to look at mortality in this population because it is a low-risk population. The reason I said I thought the study was clever is because it uses what's called an instrumental variable analysis. So, we like to have randomized controlled trials. Those are the most high quality, but they are expensive. They're not always possible to do. I think certainly the costs are justified, because when you don't study something, then you end up spending a lot of money on a treatment that may not be effective, and that's expensive too. But people tend to be more concerned, at least what I hear about is the cost of the trials. So instrumental variable analysis is a way to try to simulate a randomized controlled trial when you didn't actually have one. And so the instrumental variable, which in this case was the day of the week, has to be associated with the exposure. So they were looking at cardiac testing. What this basically means is that nobody runs their treadmill lab all weekend. So if you came to the emergency room on the weekend, you weren't going to get the treadmill test right away, and you were likely to be sent home. If you came during the week, you were likely to be kept until you could have the treadmill test, which might be later that day or the next day, and we keep people in these, what they call observation units. But however, whether you came during the week or on the weekend doesn't affect the outcome that they were looking at, whether you're having or going to have a heart attack in a year. So that's why I think it's a clever analysis, and it was supposed to assess the problem of unmeasured confounding. Like, it wasn't that you were choosing who would get the stress test by according to how sick they were. It was really just according to what day of the week they came to the emergency room. And so Ben Sun and I wrote an editorial suggesting evaluation for chest pain, time for a paradigm shift. And Ben is actually the leader of a not a randomized controlled trial, but a clinical trial working with Kaiser, our capitated managed care system in the US, to actually try to answer this question more carefully, and looking at how do people do if they don't get immediate treadmill testing, even though that's currently, as I said, with the cardiology guidelines. And so we recommended, certainly based on this study, and I think based on other studies and clinical judgment, many people should be sent home without any test. And I have been saying that for several years, probably 10 years now. I wrote an editorial in the New England Journal suggesting that was about a study, ROMICAT. These slides I had, but I took out. But ROMICAT compared cardiac CT evaluation to treadmill testing, because the argument was that cardiac CT could be done faster. And the problem with treadmill testing, you have to have the lab running and send someone for treadmill, and it's not that easy to squeeze people in quickly. But what I said was, the question isn't which test to do, it's whether you need any test, because most of these, the event rate in all of these low-risk chest pains at 1 year is less than 1%. And it's very hard to reduce that. Even if you do all this testing, you don't get less than 1%. We can't get to zero. We can't guarantee people that they're not going to have a heart attack. And no matter how many tests you do. Of course, the emergency room doctors are very concerned, at least in the US, I'd be interested to hear what it is here, about getting sued. That's what they say. They say that's why they order all these tests, because they don't want to miss a heart attack. And, I think if you have low-risk chest pain, you're really more likely to have a problem from a complication of testing than you are from having a heart problem, and that most of what we know about whether people are more likely to get sued has more to do with how well doctors communicate with their patients and explain things to them. But at any rate, this is a very controversial issue, and I don't think we're going to see a randomized trial, so I am excited that Ben is leading this study to try to answer the question, as I said, in an observational trial with Kaiser data, because it certainly keeps a lot of people in the hospital and costs billions of dollars to do all this additional testing and a lot of additional revascularizations of questionable benefit. So I was going to just talk a little bit about FDA approval processes. As I said, I'm very interested in technology assessment. And to me, the sort of low-hanging fruit in technology assessment is devices, because drugs are certainly expensive and getting even more expensive, particularly a lot of the newer oncology drugs and the CAR T therapies, but devices are not just more expensive in general, but the bar for approval of devices and getting on the market in the US and in Europe is much lower than it is for drugs. And so there very rarely are actually randomized controlled trials before a device gets on the market. So this was a study we published 3 years ago in the Less is More series that looked at a treatment for atrial fibrillation. So as you probably know, atrial fibrillation is very common. It's increasingly common as we have an older population because the chance of atrial fibrillation increases as we get older. And if you have atrial fibrillation, the chance increases that in the fibrillating atrium, particularly the atrial appendage, it could form a clot, and that clot could then go to your brain and cause a stroke. And so we generally treat people with atrial fibrillation with Coumadin or now with one of the newer oral anticoagulants to try to prevent stroke. But there are still, of course, some strokes that occur, and there are some bleeding complications sometimes from the medicines that we use to prevent a stroke. And so because it's thought that most thrombi occur in the left atrial appendage, there has been an idea for some time that if you close off the left atrial appendage, you could reduce the stroke risk. And so what had been commonly done before this in patients with rheumatic heart disease or somebody who might be at high risk for an embolic stroke who was in atrial fibrillation, if they were already in the operating room to have a mitral valve replaced, the surgeon would tie off the left atrial appendage and close it to try to prevent the stroke. So that has been happening for years. I don't know of any studies that showed that that was actually effective, but it was going on. So now that we have a shift to trying to do more things that we used to do by cardiac surgery to do them in the cath lab, there was interest in doing the left atrial appendage closure percutaneously, so doing it through a catheter in the cath lab like you would cardiac cath. And so this device, how many of you have ever heard of the Lariat device? Okay, so Lariat, you know, it's like a lasso that a cowboy would use to lasso a bull, I guess. And that's kind of what it was supposed to look like, but the idea was that it was going to lasso or tie off the left atrial appendage. And so this device received a 510K clearance from the US Food and Drug Administration. So 510K is supposed to be used for intermediate risk devices, not for high risk devices. And it's used, and the basis for this clearance is that your device is substantially equivalent to a device that's already on the market. And therefore, if something's already on the market, it must be okay. And so therefore, your device will get on the market because you've said it's substantially equivalent to a device already on the market, and the FDA agreed with you. And in this case, the company said that the Lariat was equivalent to a soft tissue. So they said it was equivalent to a soft tissue closure device after abdominal surgery. It's basically a stitch that would be used to close the abdominal wall after surgery, which is clearly not, to me, the same as going inside someone's heart and putting a closure device inside the heart over the left atrial appendage. And the company, according to this paper, never mentioned in their FDA documents that that was the intended use of this device, although the company's, it could have been a hint because the company's name that makes the device was called Center Heart. And in their patent application for this same device, they clearly indicated that it was meant for left atrial appendage closure. However, in the FDA document, it just said that it was similar to this soft tissue suture that was going to be used for abdominal closures. The FDA cleared that device on that basis. There were no clinical trials done, and that meant that they could then use it in the heart, and that would be then off-label. So not for the indicated use, would be on-label for like the suture, but off-label. So they did that, and what this study was an attempt, I think it was done because some of these cardiologists had seen complications in their patients who had these devices. So they went through all of the literature to look for how many reports there were of this usage in humans, and they found 5 published reports, and this is fairly typical for device studies, which tend to be a lot smaller than other studies, like drug studies. And they found that there was successful closure of the left atrial appendage reported in 90% of those studies. There was no data actually on whether they reduced atrial fibrillation, whether they reduced risk of stroke, which was the real outcome that was supposed to be the benefit for getting this device. But they also found potentially concerning complications, like 2.3% of these patients had to have urgent cardiac surgery because of complications. Things went wrong during the lariat placement, and that there was 1 in-hospital death associated with this device. So when we published this study, I think the FDA issued a safety advisory about the device, and the National Cardiovascular Data Registry, which is a registry in the US that collects some data, and I would say our data registries are nowhere nearly as extensive or complete as they are in Finland and most of the Scandinavian countries, where I think you have much longer and wider tracking of patients. But they did announce that they would be tracking the results of this device, and my understanding is that the device is still being used, I think, in the US and abroad, but that its usage has declined somewhat. So we could talk again about medical devices and their use, but just an example of what I think are some of the issues with not getting clinical data before approval of these devices, which clearly are high risk. Obviously, a device that could lead to cardiac surgery or death, I think, is high risk and should not have gone, in my opinion, through that 510(k) clearance process, which is not intended for high-risk devices. So this was a study just looking, again, at imaging tests and how we tend to like to use imaging tests. This was a study from an international group led by some Italian researchers from Milan, which looked at the prevalence of pulmonary embolism in patients with syncope. And so I think there had been a previous study suggesting that patients with syncope or passing out might have pulmonary embolism that led to a lot of increased use of testing for pulmonary embolism. So they analyzed almost 2 million patients in this international study who presented to the emergency room because of syncope or passing out. They found, in contrast to the previous study, that actually very few of them, only 1% of all patients with syncope had a pulmonary embolism. 3% of patients, if you only looked at the patients that actually got hospitalized for syncope, so still very low. And they said that there was no need, so basically contradicting the previous study, that now there was no need for routine protocol to exclude pulmonary embolism because the prevalence was too low and the risks and costs were too high. So again, we tried to publish things. This was published in the Less is More series that point out tests, treatments, or imaging that have no known benefits because, again, you're just left then with the harms of the additional testing, the contrast, the radiation, the keeping people around. Okay, so I wanted to just spend a few minutes on the subject of statins because often people Socially, actually, I have to say a lot of colleagues, it turns out, are on statins, as well as it being a very common topic at most medical and other meetings. So because I've written a few things about statins, I often see patients who self-refer, as our too much medicine challenges, people told us, people most commonly go to Google when they want health information. And I do see people who have Googled someone or who's not very aggressive about statins. So anyway, this was a 68-year-old man. He had no history of cardiac disease. He had good blood pressure. He didn't smoke. But because his LDL was 108, and some of the guidelines say your LDL should be less than 100, which I don't agree with, he had been placed on a statin for hyperlipidemia. And I would say he also had a negative exercise nuclear stress test. So he'd really already had a lot of testing before I saw him. He then flew up to California. He said that he really was miserable on the statin. He had been unable to exercise due to muscle pains, but when he told his doctor, the doctor said that he could not go off the statin because he had hyperlipidemia. And he was very upset about this because he was miserable. As I said, he wanted to be able to exercise, but didn't want to have a heart attack, and that was his concern. So, as I said, I think he came to see me, among other reasons. I had written, among other things, in the Wall Street Journal, kind of because it's a very controversial issue. Myself and another cardiologist who very much believes in statins had each written a piece. I said, healthy people should not take statins, and he said healthy people should take statins. So I just want to show you that the Wall Street Journal ran this vote, and 71% of people said healthy people take cholesterol drugs? 71% people said no, and 28% said yes. And obviously, I think people only want to take medicines if they think there's some benefit for them. So that's the data I wanted to address. So the question is there benefit for healthy people, people that do not have heart disease, to take statins for primary prevention? And I think there have now been a number of meta-analyses of this study, of this topic, and depending on whether you only include people for primary prevention or whether you have a mixed population, which some of them do, where they have some people that have established heart disease, so secondary prevention, where there clearly has been shown to be a benefit for statins. So if you mix those in, you can show a small benefit in the populations where they took out the people that were known to have heart disease, like that had already had a heart attack or bypass surgery. I was thinking you could say conclusively there's little to no mortality benefit for statins. There might be a small benefit on cardiovascular events, but no benefit on mortality. So you won't live any longer, and that adverse effects are common and underestimated because, unfortunately, very few of the trials ask about adverse events. Even when they record sort of muscle problems, a lot of the trials only include if you have an increase in your CPK-MB and your muscle enzymes, where most people who have muscle aches and pains after starting statins don't have a rise in their enzymes. But unfortunately, a lot of that data never gets recorded, and the data that is recorded is not available. It's been held by the group at Oxford, the CTT, the Cholesterol Trialists group, that does not, and say they're holding it on behalf of the industry sponsors, and it is not made available to other researchers to look at. So we don't have a lot of data on the percentage of adverse events. This was a study published in Archives of Internal Medicine 2010 from a British group that did a very careful, it's probably hard to see, but the only point of this is that they did a very careful meta-analysis where they only included patients who did not have known heart disease, but included a lot of high-risk people. What I think you can see, this is the forest plot, is that the lines sort of cross one, so that there was no benefit on all-cause mortality. The overall, I think it was like 0.96, 0.97, the hazard ratio, with the confidence intervals crossing 1. So as I said, there would either be little or no benefit on mortality. I think I'll go through I'll say, so the other reason besides the snow that I wanted to come to Finland was because I've heard so much about the saunas. And so I first learned about the saunas from this article on the benefits of sauna bathing and fatal cardiovascular and all-cause mortality. So this was a study that came from Kuopio, I think, is that how you say it? And where they basically followed a population of middle-aged men, where they compared increased frequency and longer duration and found that the men who took longer and more frequent saunas had a lower risk of cardiac death than the men who took less frequent saunas. And I have to say, when they sent us this study first, I said, well, what about the control group that doesn't take any saunas at all? And they said, well, nobody in Finland doesn't take saunas, so we could only compare the men who took one sauna to the men that took multiple saunas per week. And of course, I mean, we did, they said they were going to include women, which I think they did in their next trial. But we thought, you know, one could argue that perhaps people that have more time for saunas also, you know, are in better position than people that don't have so much time for saunas. But it certainly seemed like a reasonable conclusion that there were also health benefits to the saunas, either the sauna itself or the fact of having some relaxation time or perhaps having sauna with friends and family. So we were certainly convinced that this was a benefit. And as I said, in that same group has gone on, this is a more recent study from the Journal of Human Hypertension, and I think they're looking very closely now at what are actually the physiologic benefits to saunas, and they've been looking at the impact on all these different, you know, arterial stiffness, blood pressure, and biomarkers to better understand on a physiologic level what are the health benefits. And so they have found that it has positive effects on arterial stiffness and decreases in blood pressure. So I have to say that we have been enjoying already the saunas in the hotel that we stayed at in Lapland. I could maybe just talk for a few minutes about another example of medical devices. This was a study, well, I'll go back. This was a research letter we published looking at inferior vena cava filter use and the 2010 Food and Drug Administration advisory. So just to give the history of why there was a 2010 US FDA advisory, we published a study back in 2010 that came from a cardiologist at a community hospital in Pennsylvania. And what he had a patient who had come to him with severe chest pain, and when he did the examination, realized that she had actually had a puncture of her pericardium, the sac that covers the heart. And it turned out that she had had a year before an inferior vena cava filter. So these are these little umbrella devices that you can have put in your inferior vena cava, the main blood supply from the legs coming up to the heart, to prevent a blood clot from reaching your heart. And so she had had one of these devices placed, and the device had fractured and gone up and punctured her heart sac, and it was a catastrophic complication. And so he very responsibly decided that he should see whether the other patients, because this was a commonly used device, the other patients at their hospital had the same complication. So he called in all of the patients and did this imaging to look for fractures, and it turned out that there was a fracture rate of, I believe it was about 25% for this particular, he was looking at barred recovery filters. And so had reported that. He told us actually that he had reported his findings to the FDA before he submitted the paper to us, but on the day that we published the paper in JAMA Internal Medicine in 2010, the FDA issued a safety warning saying that they had almost 1,000 serious adverse events associated with inferior vena cava filters, and that people should beware, and that in particular, they should retrieve the filters, because these filters were actually not meant to be left in you forever. They were meant to be left in for the immediate time that you were at risk for the blood clot, which is usually 3 months, and then to be removed. And they think a lot of the problems were coming because they weren't strong enough to stay in your bloodstream, and that's why they were fracturing. But the retrieval rate on the retrievable filters is only about 7%. So they were, for a lot of reasons, being left in. And so the day we published that article, the FDA issued this advisory. And so what this study looked at was, what was the effect of that advisory? Did people stop putting in filters, or did retrieval rates get better? And so they used a national inpatient sample, and they started before the advisory and went till after the advisory in this 10-year period. And as you can see, there was some effect. Here's the advisory, and so here there was about 40 per 100,000. It had been going steadily up, and then with the advisory, it did go steadily down, although clearly not going towards zero. And here was trends in venous thromboembolism. So again, it's, I think, always important to look at outcomes. So what's the reason we're putting in these devices? It's supposed to be to prevent venous thromboembolism. So as you can see, even though the devices did drop off somewhat, there wasn't a change. It's not like there were more venous thromboembolisms occurring even from less use of devices. And I will say IVC filters is another one of those high-risk devices that got approved through 510K clearance. There were no clinical trials. There have subsequently been clinical trials done that have not shown benefit on venous thromboembolism, but the device remains on the market and in use, although there has been some decrease in their use following the FDA advisory. And as with most things, we use a lot more of them in the US compared to Europe. So they are still used in Europe as well. But I think, at least currently, rates of use of this device and a lot of other devices are generally higher in the US. The last example of low-value care, which I thought was interesting, is that one of the things that Medicare, so the US government does cover for everyone in the US, is dialysis. So if you have end-stage renal disease, you are eligible for Medicare, and the US government will pay for your dialysis. And so this study looked at all of patients getting dialysis and when they start dialysis. And basically what it found is that there's been a trend towards earlier start of dialysis. So people that have not terribly impaired kidney function, like EGFRs, in the US, I believe people are starting at around, 15. EGFRs of 15 are getting dialysis, but compared with patients who start at less than 5, patients who start earlier, like at 15, have an increase in mortality. So again, the idea is to start earlier. Somehow this is a benefit. There's a lot of screening being done now for chronic kidney disease, which I think a lot of screening programs have the effect of starting people on treatments earlier than they would otherwise, just because of that contact with the medical system and the belief that treatment is often better. I think clearly, and this was an editorial written by some nephrologists, early start of hemodialysis may be harmful. And again, it showed, as I showed you, that the creatinine level at which dialysis initiated has dropped. So again, we're starting it with people that have mild impairment as opposed to severe impairment. And that currently in the US, half of patients are starting dialysis with a GFR over 10 mLs per minute. And I don't know if anyone here could tell me, I believe that that is much higher rate in Europe. I think the rate that people have told me in other European countries is less than 5 generally is what's used.
Do we have any nephrologists in the audience? We can come back to that later.
All right, I'd be interested to hear it. And so look, I'm going to close with deprescription, which I think the winners for our Too Much Medicine Challenge were talking about their unnecessary medication challenge. So I think it fits well with the deprescription idea. And the idea of deprescribing is that we have gradually increased the number of medications everyone's on, particularly our older people. And so this was from our, as I showed you, the Teachable Moments series, which I also want to plug. So this was a 88-year-old man who presented in the emergency room who was on 2 medications, an angiotensin-converting enzyme inhibitor and an angiotensin receptor blocker, which are both vasodilators. They work exactly the same way. And even though, and prescribing both of them tends to lead to more adverse drug effects from low blood pressure. He did have a medication review, but somehow did not have an adjustment, and so he did have some problems, and it was written up and published in the Teachable Moments series with the idea that to be more vigilant about opportunities for deprescribing, that we should all be paying attention to the idea of when we can stop medications, and that deprescribing is the systematic process of identifying and discontinuing drugs in which the harms outweigh the benefits. And I think for a lot of reasons, sometimes, you have multiple doctors, so one doctor starts one medication, another doctor starts another medication, and it's hard to reconcile those medication lists. Perhaps patients don't bring all their medicines to their appointment. It's hard to keep track of what you're taking. Or sometimes medicines get started and we forget to stop them. For all of those reasons, people end up on a lot of medications, and I think it's a really good idea to periodically review them and try to stop the ones that aren't necessary. As I said, the Teachable Moments series, as this was submitted, is particularly for trainees. So the first author has to be a trainee, and then the senior author should be the trainee's mentor. And they're sometimes on overuse, they can also be on underuse, but they're basically to share things you've learned so that it always presents with a case, and then there's a little literature review, a mini literature review, and then sort of the teaching points, the teachable moment. And so we really I encourage any trainees to send us these articles. And I just wanted to thank, these are the editorial fellows that I mentioned, but certainly I get a lot of pleasure and a lot of help from all of my co-editors at JAMA Internal Medicine. I wanted to conclude by just a few comments on sort of the bigger picture of healthcare, and then hear from you any questions or concerns or comparative discussions. But as I said, I think to get to a high-value care system, one of the first things we have to do is make sure that what we are recommending, what is out there, what we put on the market, are things that are actually have good evidence that are likely to benefit patients. I do look particularly at high-risk devices because so many devices are implanted, and once they're inside someone, it's very hard to remove them. You can't remove a metal-on-metal hip or the cardiac defibrillator or other things, so it's good to know beforehand. And I think to have high quality evidence means a randomized clinical trial. It should have meaningful clinical outcomes, and by that I mean not just the lab measurement. Say a lot of people take statins to lower their cholesterol. That's a lab measurement. You don't feel better because your cholesterol is lower. And so unless it actually is going to be correlated with meaningful clinical outcomes, which are things patients can feel, I don't think that that's a good enough reason to be recommending something, because I think we're in the business of doctors of either helping patients to feel better or helping them to live longer. I think particularly for devices, the trial should be blinded if feasible. How many of you are familiar with the Orbita trial that was recently published in Lancet? So a few of you. So Orbita was the first, I'm interested in what you thought of it, but it was the first blinded study of stenting where, even though we've been doing stenting for many years, almost 30, this was the first time that there were two groups where both of them thought they got stents. There were real stents and then kind of sham stents. And they had a number of outcomes, and there was no difference in the outcomes in either group. And now there's some debate over whether the guidelines should be changed. There's a lot of resistance once a practice, as I said, is established, and that's certainly true for stenting. It's making a lot of more friends for me on the interventional cardiologist, though, because the editorial that a colleague and I wrote in Lancet to go with that article was Orbiter, Last Nail in the Coffin for PCI. But I do think that device trials should have blinded control arms, because there's a lot of benefit just from doing a procedure, and you have to know, is the benefit coming from your procedure, or is it coming from just, a placebo effect? Okay. Cost control features that are used in other countries are global budgets that seem to work, price negotiations most countries use. Healthcare is a very different market than most markets because prices are often not transparent. Patients often don't have all of the information. It's very one-sided, and there's often a lack of competition. Primary care workforce, certainly when I was in Britain, everyone got a GP, and all of your medical care, your specialty care was supposed to go through your referrals through your GP. There can be restriction of covered services. Some countries can use cost-effectiveness analysis in order to evaluate what to pay for and what not to pay for. Often, even in systems that are publicly insured, there can be use of supplemental insurance. So I think certainly the trend overall, and certainly in the US, is to moving away from fee-for-service payment to what's called value-based payment, but looking more at outcomes. But this is a very slow-moving trend, and certainly not making, I would say, a lot of progress in the current administration. I think it's important to remember that tests are not always necessary and not always helpful. Certainly, they can be necessary and can be helpful, but they can also be harmful. That we can effectively reassure patients just by talking to them, and that more care is not always better. So I think there are a lot of different directions we can go. I think to really make a difference and have more high-value care will take a culture change, because right now I think more care is kind of in the culture of medicine, and we just need to be a little more thoughtful about it. I think physicians and patients all need to be talking, and part of the solution will require, I think, multiple strategies to make changes. It's not easy to change culture, but we should not get stuck in the sand. All right. Thank you.
Thanks a lot. Thanks a lot, Rita, for excellent talk. We have the catch box, so I can throw it to you guys. So who wants to be the first to?
Oh, that's the microphone.
This is the microphone.
That's cool.
So who wants to be the first one to comment and or ask or on the talk? Yeah, please. There's one of the pioneers of too much medicine, Hans Blomberg from.
Yeah.
So, please.
Well, thank you for a very nice, good speech.
Well, thank you.
I would ask you about hypertension. Mm-hmm. You got new guidelines in the United States. So most of us older people will be on some kind of hypertension medicine. What's your opinion?
Yes, thank you. We have, again, conflicting guidelines, I think, now in the United States.
So why don't you tell about the ACC, AHA guideline, and then everybody knows what we are talking about.
Sure. Right, so the most recent cardiology guidelines, the American College of Cardiology, American Heart Association guidelines, lowered the level at which we start calling people hypertension, like to 130/80, whereas the previous guidelines, as you know, the JNC 8 had sort of raised the level, and there was a lot of discussion over we don't get much benefit for treating people to lower than 150/100, but I think mostly based on the SPRINT trial, which was a little bit controversial, which we could talk about. Those guidelines lowered the levels, and all of a sudden, a lot more people are now labeled as hypertensive. I don't, and now I think the American Academy of Family Physicians, the American College of Physicians, I'm sure the AAFP has come out in opposition to those guidelines. I think there were issues with SPRINT, as probably know, SPRINT was the NIH-run trial, but one of the issues was the way they measured blood pressure meant it wasn't like what anyone else is ever going to get for blood pressure, because they had patients who were in a quiet room where nobody could talk to them for 5 minutes, and then someone went in and in a very still circumstance used a manual cuff and did their blood pressure. And so they estimate that those blood pressures were 10 to 20 points lower than what we get in practice. So for their 130/80 is probably what most people are measuring at 150/100. So, and in fact, there was just a more recent study that came out a few days ago that showed that office pressures are generally much higher than what people are measuring accurately at home. But at any rate, I think SPRINT did, and
just to clarify, so
yeah.
they were actually probably in reality having way higher blood pressures than what they had in the trial setting.
Yes, exactly.
So they were
because what they
higher-risk
did in the
patients.
trial setting is what nobody ever does. Nobody leaves
Yeah.
patients alone for 5 or 10 minutes where nobody talks to them and then goes in and measures their blood pressure.
Yeah.
Right. I mean, most people, all my patients who have their blood pressures measured tell me that's much higher than I get at home, but I couldn't find a parking spot, the train was late, I was worried I'd be late, there were all kinds of, they're generally not coming to the doctor's office feeling very relaxed, and the SPRINT people said that the pressures they got were lower than what you would get, from measuring the way office pressure is usually measured. And of course, as you know, I think the harms are that like that patient, that 88-year-old patient, a lot of people are on too many medications for blood pressure, and we know there are a lot of falls in the elderly that are on several medications to lower their blood pressure. So I worry about that. The other thing is that blood pressure fluctuates so much over, we know from ambulatory blood pressure that your blood pressure changes over 24 hours. And so we always tend to, if there's one high reading and 3 low readings, we're going to try to treat the high reading. But that means all the times that your blood pressure is getting lower, it's probably getting a lot lower, and I think that explains the falls and the dizziness and the problems. Actually, the case that the Too Much Medicine team gave as an example of their deprescribing was an 82-year-old man who was dizzy from too many medications, including blood pressure lowering. So I don't know, what do you think about the new cardiology guidelines with the lower pressure?
I think you shouldn't start with people that feel well with very low limits. So I think, but once you start, I think you should you should go out for 140 and 85, or 135 and 85 in home measuring. We have a lot of people that have their own blood pressure
Yes.
measured at home, and probably we can get better results of that. And the office measuring, I think, is not good anymore.
That's a good point.
Very good. Yeah. Give me 1 second. You can catch.
Thank you for the very interesting presentation. You told about how in the US, was it 510, this approval process for the devices, it's sometimes sometimes too easy.
Yes.
And also it can be, or is easier to get approval for a device than a drug. Do you know, is it similar in the EU, and also is there unified system in the EU, or does it vary country by country?
Okay, so no, it's not harder in the EU, and in fact, I believe that it's considered slightly easier in the EU to have devices approved than it is in the US. My understanding, if anyone here has more, but it's country by country. But the issue is that, first of all, there aren't clinical trials required, although they might be done. But you have to get, it's called a CE mark, a certificate of something, mark from what's a notified body. But the notified body who does the evaluation is hired by the company of whoever's applying for the certification. So there's a little conflict, because they're going to get paid, based on on their certification, but obviously they want to get more business. So I think that system kind of introduces inherent conflicts. And my understanding is that there is not a very strict evidence bar, and there also is a lack of transparency. So the reasons for the decision are not published. So in general, I think device approval is even easier in the EU, but I think because devices are still not used in the same high numbers in the EU in general as they are in the US, it varies somewhat from country to country, but some countries have global budgets, some countries have fee-for-service, some have more public, government-run systems. But I think there is just less of a culture of overuse of some technologies to the point that there is in the US, although I think the numbers are increasing everywhere in the EU and in the US, but we started so much higher. The other difference in the US is prices are much higher for everything. So the same devices I think EU is much more successful in keeping down prices due to negotiations than we have been in the US, where prices are always much higher for drugs and devices.
At some point of the lecture, you were saying that we do a better. I mean, in some issues, I agree that we do a better job, and there's less overuse here. But then you were, which I'm not really sure. I would like to hear from the audience also. But you were saying that we would record better the use of devices or something. But I can tell, at least in my area, in urology, we unfortunately we just put the slings and all kind of devices, and we really don't follow them. There's no.
Not in the medical record.
So the medical records, unfortunately, they are not prospective. Sometimes there may be a study when it's a prospective. There may be differences in some of the. There's in the audience some of the orthopedic surgeons. They may want to comment whether they actually, when they put the metal and all that kind of stuff, may be different. But at least in urology, when we put slings and other devices, there's no there's no registers which you can easily find the complications, unfortunately. But we are improving. We are now doing more and more to that direction. But it's usually in a setting of a research study. So I don't know if there's anyone in the audience who wants to comment on the issue. Okay. So we have had a pretty long day, and I'm really thankful for all of you coming here. If you don't have any other comments, we will stop. This is going to be available on YouTube. So if somebody thinks this is helpful, please share the knowledge or watch again. And two issues. So first of all, there's coming another on October 17th. We are going to have a Mohit Bhandari, who is a Indian-Canadian world leader of evidence-based surgery.
Great, yeah.
So he's going to tell us. He's a pretty a North American speaker. So he will tell a story how he has created a massive trials and how they were successful in that, and then obviously go to toomuchmedicine.com and we will have an amazing meeting here in August. I welcome on behalf of the committee everyone, and so thanks for coming here, and big thank you for Rita, and so.
My pleasure. Thank you.
Palave on päättynyt.